Hello, everybody, and thank you for joining us for what I hope will be an interesting discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from the Griffith University in Brisbane, and today I'm delighted to be joined by Dorthe Berthelsen, who's a PhD student and a physiotherapist at the Parker Institute in Copenhagen and at the University of Southern Denmark. It's a pleasure to have you join us today. We appreciate your time. We're going to be talking about one of your recent papers, which I thought was very interesting and quite important, and an aspect of clinical care that most clinicians don't pay a lot of attention to. And it's entitled, "I Couldn't Carry on Taking a Drug Like That." It's a qualitative study of patient perspectives on side effects from the rheumatology drugs that we use. And it's been recently published. I think it was in Rheumatology, but we'll track that down precisely. So tell us a little bit about yourself first, your background, what your interests are, what you're working on, and where you work.
Well, thanks for inviting me to this discussion. My name is Dorthe Berthelsen, and I'm a physiotherapist and a PhD student at the Parker Institute in Copenhagen, Denmark, and the University of Southern Denmark. And I also work at rehabilitation. And I'm interested in side effects from the patient perspective. And that's also what my PhD is about.
Excellent. And your paper is part of an OMERACT safety working group. So tell us a little bit about the objectives of what you were trying to do with this particular study.
First of all, OMERACT is an international community of patients, clinicians, and researchers which aim to improve outcome measurement and instrument methodology across rheumatic and musculoskeletal conditions. And in this study, we have investigated what patients with rheumatic and musculoskeletal conditions consider important to know about symptomatic side effects they might experience from a new prescription drug. So what we did was that we invited potential participants to the OMERACT community, and participants were also encouraged to pass our study details to other relevant patients. And patients were eligible if they had a confirmed diagnosis of inflammatory arthritis, that is rheumatoid arthritis, psoriatic arthritis, or axial spondyloarthritis. They had to be over the age of 18 and had to have taken one or more prescribed drugs for their disease for these 12 months. So
and 12 months was an interesting time point. I wonder if that means you miss out on people who drop out or discontinue early because of side effects. And if you stay on something more than 12 months, it almost sort of biases towards doing okay, not getting side effects. Was the 12 months an important time point?
It was more to make sure that the patient had experience of taking rheumatoid drugs. So it didn't really matter what kind of drugs they were having, and they could also have tried different drugs. So it was more to make sure that they had some experience with drugs that we chose the 12 months.
And was language an issue? Was education level an issue to understand the questions?
We tried to include patients with various educations, and we also had patients from 3 different continents. So we had patients from Europe, from North America, from Australia. So we were trying to include patients with different backgrounds to make sure that every perspective could be covered in a study.
And the questions you asked, has that already been OMERACT study group worked out, what questions you ask, or you invented your own set of questions?
Well, we were actually building on a previous qualitative study that was done some years ago by OMERACT, where we investigated patients' concern in DMARD use. And for developing our questions, we also talked to patient research partners that help us to form the questions that they thought would be important for our study. And yeah, well, we did our discussions online with patients, and we had all in all 34 participants in 7 focus groups. We had 4 participants from Europe and the Middle East. We had 11 from North America, and we had 9 from Australia. They also had a mean age of 58 years. 2 out of 3 were women, and most of them were white. Nearly 60% had RA, 20% had PSA, and 20% had AXPA. And their mean duration for disease was 23 years, with a range from 2 to 50 years. And most of our participants were currently taking biologic DMARDs. So I think we covered as much as we could in our focus groups.
But I think that is an important distinction. 20 plus years of disease, fair amount of damage, had a long patient journey with different medications over a long period of time.
Yeah.
And 2/3 on biologics, more than half on steroids. This is a sort of a chronic, long-standing group of patients. So they will have had a lot of experience with different medications and treatment over many years. So tell us a little bit about what your findings were, and whether the fears and harms and benefits had a theme in all the different patients.
Yeah, we found various aspects important from patient perspectives. There were 2 aspects that kept coming up in our focus groups. One was the balance between benefit and harms when trying a new medical treatment. And the other one was this cumulative burden of having more than one side effect at the same time, or the persistence of side effects over time. And we also learned from patients that they considered the impact on life to be very important. And that would cover 4 aspects. That would be their daily life, such as the quality of life. That would be their family life, their social life, and their work life. And we also learned from patients that both the physical and the mental aspect was important to them. The physical impact was their ability to function, while they described the mental impact as it could be emotional dysregulation, such as mood swings, but it could also be more overall mental state of feeling low due to side effects. Moreover, patients told us that they felt the time, energy, and economic burden could also be a side effect. And time and energy was more related to if you had to go to more regular visits with your doctor at the health hospital, or if you had to have extra blood tests taken, where the economic burden was more related to that you could have to pay for your medication, which can be pretty expensive. And if you have side effects, you might need even more medication, which can also be expensive. We also learned from patients that they considered frequency, duration, and severity to be very important measurement issues. So we had a lot of findings, a lot of aspects from patient perspective that was important. But this balance between benefit and harm and the cumulative burden was very crucial to the patients.
How do you analyze results like this? How do you analyze a whole series of statements by a whole series of different patients?
Well, we recorded our online discussions, and then we anonymized them and we recorded them, and then we analyzed them using thematic analysis. And we could group all the quotations from the patients into different themes. And from that, we could group it into more overall categories that could sort of explain what was important for patients.
And having different continents, you'd have different healthcare systems, different costs, different access to medical care.
Yeah.
And how did you allow for those differences? Or did you think the comments they gave were important, not so much that background?
Well, we saw our patient as one group, so there might be some quotations that were more important for patients, for example, in North America, because you have to pay for your own medication there. But it was important to us to include a various cohort of patients so that we could cover most aspects. But we still saw the patients as one group. We did not analyze whether there was any differences depending on where people came from.
I think it's very important, two aspects. One is patient education and the other is compliance with medication. Every guideline talks about shared decision-making and giving full informed consent. I just wonder if these patients were given an adequate amount of information before they started their drugs about both benefit and harm. Did you get a feel for what they were told?
Yeah, some patients felt well informed, by others said they could use more information. And I think it's a very important issue, because what we are hoping to gain from this study is also that we now know what patients consider important to know about side effects in medical treatment. And that would allow us to develop a patient-reported core outcome measurement instrument to complement the clinician's reports in clinical trials. And a few years ago, we did a systematic literature review where we searched for side effects that were reported in clinical trials. And it was very different what was reported in those trials. It was very inconsistent. So I think if we could develop a core outcome measurement sets that addresses patient perspective, that would allow side effects to be compared between trials in meta-analysis. And I'm pretty sure having more knowledge from the patient perspective about side effects, that would increase the usable and patient-relevant information for decision-making in clinical practice.
And what about compliance? Did the patients say that they stop and start medication given these side effects, and that they often don't tell the clinician when they've stopped and started, and it must affect compliance?
Yeah, some patients could start and stop on their own, but other patients were very dependent on their doctors, so they didn't change their treatment on their own. And it could be a problem if the practitioners that didn't believe in the side effects that patients were having. So some of our participants explained that they have been on a drug that actually had quite a few side effects for a very long time because their clinicians didn't believe them.
Okay, so I think that's fairly critical as well. And more recent years, patient-reported outcomes are included in every clinical trial. And we've been reporting number needed to treat for remission or low disease activity, and number needed to harm, driven by mainly serious adverse events. So do you think there has been improvement in listening to patients in clinical trial?
I think there has, but I think we can do even better. And especially about side effects, because when you read most articles on clinical trials, they are focusing a lot about the beneficial effects. But I think less attention has been to the patient perspective on side effects. So I think there's room for improvement, even though it's going in the right direction.
Yeah, that's interesting, because from the clinician point of view, I get the feeling we hardly ever talk up the benefits, stopping damage, but we spend a lot of time telling patients about side effects because we're all afraid of medical legal issues. So I'm surprised that that sort of doesn't come across in your interviews.
Yeah, you can say so, and it can be kind of surprising, but from patient perspective, a lot of the patient that was involved in our study, they wanted to know more.
And the other thing that we were taught when we looked into this some years ago, when we Joseph Smolin started the Treat to Target movement, and there was patient involvement. The patients said that they're afraid of becoming addicted to their medication, and that they often take a medication now fully expecting it to damage heart or kidneys or liver in the future. They're afraid that it'll accumulate and cause a future problem, but they'll take it now because it's important. Did any of that come through in the interview, or is that old hat now?
Yeah, a long-term effect was also mentioned in our interviews, but some patients also mentioned that they weighed it up against the benefit against the harms. And one patient in particular mentioned that she weighed it up whether to have a better life now than having to live longer. So for her, it was more important to have a good life, now than it was to have a longer life.
And did you get a feel, given this relatively small number of patients, whether different medications had different set of adverse effects, if you know what I mean? Whether the people on steroids were different to the people on a biologic, or different to people on a DMARD? Was it possible to get a feel for which of them caused the most nuisance side effects?
We did not have data enough to say anything about that. So the overall purpose for our study was to find out what patient thought was important. So we did not analyze whether it was depending on what sort of medication they were having.
And you couldn't have told if there was a gender difference because they were mainly female, I suppose.
Yeah, 2 out of 3 were females, right? Yeah.
Yeah, so that would have been an interesting aspect to look at as well, because we're finding, particularly in PSA, that women have higher baseline disease activity and a lesser response to therapy. And I wonder about the adverse effect profile between the two sexes, so that between gender, so that might be an important issue in the future. So tell us a little bit about your conclusions and some take-home messages for the clinician as far as your study is concerned.
Yeah, I think the main conclusion is that we have to look more into this accumulative burden, to this impact on life. And the clinicians should also know that it's something that patients really want to know something about. And we actually also discussed how to measure this accumulative burden with patients in our study. And there were no clear suggestions on how to measure it. Some suggested that quality of life might be a way to measure it, but quality of life doesn't have a clear harmful direction, which can make it difficult to compare when you're evaluating benefit against harms. And that's why also our next study is focusing on this accumulative burden, on this overall trouble from side effects. So we will look into that in our next study, how we can better measure that, if there's any measures we can use to address that very important issue from patient point of view.
You actually propose a target domain, specific domain for this aspect, which I think is relevant and important as well. I wonder how much patient anxiety, patient psychological state, patient depression affects a lot of this. Is that measurable?
Yeah, it could be that maybe a composite outcome would be able to cover all of these aspects that are important to patients. So that's one issue that we're looking into. We're also looking into whether there could be one single overall measure, such as patient-reported bother, that could maybe cover all of this. But that will, I hope our next studies will allow us to find out more about that.
Well, I hope that clinicians listen to their patients. I'm getting the impression that they don't pay as much heed as they should for things that are particularly nuisance.
I think it's a balance in clinical practice. I have no doubt that doctors want to help the patients in the best way ever. But as patients in our study also emphasize, we are all different, we all have different needs. So that also means that in clinical practice, it's very much a balance of when to change therapy, how much you need to discuss side effects with patients. But it's definitely something that is very, very important to the patients.
It certainly is, and I congratulate you for doing this work, because I think it can only help patient education and compliance long term. So we should pay attention to symptomatic side effects, even if they're nuisance, the impact on life quality, that includes both physical and psychological, patient time, energy, and finances, which we tend not to pay any attention to. I haven't heard anything about effect on sex life, which I think is very underappreciated by clinicians, and I'm sure very important to patients. The financial burden, I don't know how much of that is changeable, but clearly is a major issue. The measurement issue is one that we hope you can help us with, validate good measures to sort some of this out, and then concentrate on benefit versus harm balance, which will be different in different patients.
Exactly.
So we greatly appreciate your time. Any final comments and where you're moving next?
Well, our next move will be to investigate this overall burden for patient, this bother from side effects. And then we are working on an instrument that include multiple measures as well. So that will be our next steps.
You can call it the Berthelsen Adverse Effect Activity Index.
Yeah,
so that'll be very nice. We look forward to that. Thank you again for your time. Greatly appreciate it. If you'd like to know more about this paper published in the Journal of Rheumatology, others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you can get detailed slide sets are available in the publication section, imidforum.com. Please subscribe to this podcast on Spotify, iTunes, or other podcast media. Let's know what you think. You can also watch us on the IMID forum on YouTube. And finally, you can follow us on Twitter, LinkedIn, and Facebook to keep up with all the latest data in the immune-mediated inflammatory disease area. All coming, more slide sets, more publications, more papers in 2024. Thank you so much for your time.
Thank you for having me.